Hi, my name is Srinivas Murthy from the University of British Columbia in Vancouver, Canada. I was asked to speak about pediatric critical care trial design and novel ways to expedite generating knowledge in critically ill children. Um, Thank you to the organizers for this opportunity. My disclosures, I receive funding from Innovative Medicines Canada as the Innovative Medicines Canada Chair in Pandemic Preparedness Research. So I'm going to go through a few short chapters addressing some problems and some possible solutions. The first problem to generate knowledge in critically ill children is numbers. And I think that's evident. Taking COVID-19 as an example, this is data from across North America, cumulative daily admissions. And you see numbers in the teens or single digits, and this is across nearly 200 North American ICUs. Obviously, the numbers are very different across adult ICUs around the world. And so the first problem, obviously, to generate new knowledge in children from a clinical trial perspective is the small numbers of critically ill children. When you look at our clinical trials, this is a great resource, picutrials.net, which systematically reviews every clinical trial that's done among critically ill children around the world, and it's constantly updated at that website. If you look at the numbers of children randomized per trial over the past 30 years of clinical research, it hasn't appreciably changed, and it remains quite small, within the 50 to 500 patient range, with very rare trials extending above that. Second problem is our low event rates. As you can imagine, mortality in children is much lower than that in adults. If you look at all trials published up until 2013, nearly 3/4 of them with dichotomous outcomes had an effect size that was smaller than that expected in the sample size calculation. So regardless of which outcome is chosen in our critical care trials, we often underpower them. Not that I'm a true believer in fragility index, but as a marker of sort of the overall scope of trials that are being done, the fragility index across all PICU trials is quite low. The third problem is heterogeneity. And obviously this is a problem that much of the critical care world, both adult and pediatric, wrestles with as relates to interpreting and performing high quality clinical trials. In children, it's magnified by the differences between a 1-month-old and an 18-year-old and a 9-year-old, both from a disease presentation perspective and a response to therapy perspective. One can envision lots of different ways, both biologically and clinically, how management would differ, and incorporating that degree of heterogeneity into a single clinical trial becomes complicated. And obviously, heterogeneity exists around the world as it relates to how children are managed. And this is not unique to children. Loss of equipoise, and I think this is the fourth problem, which is a major one. You take adult clinical trials, which proceed at much faster rates than children, and you see different responses. Say, for example, the steroid trials in septic shock. Over the past number of years, we've seen salient and seminal articles reporting results from the administration of steroids in septic shock. At the same time, in children, we've been working globally on steroids and sepsis. And does our equipoise shift with the integration of adult data? I.e., can we still do these studies when indirect data is available? Similarly, high frequency oscillation, for example, 8 years ago now, the OSCAR and OSCILLATE studies have emerged in pediatrics. Do we still have equipoise to study this or implement this? And studies are ongoing with this exact question, but with challenges as it relates to equipoise. And the fifth problem, I think this is fundamental, is that we need child-specific data from an ethical perspective, from the biological differences that's discussed, and obviously from a regulatory perspective. Our governments want child-specific data to better inform policies from an equitable access perspective. So, what are some possible solutions? One mainly is to learn from adult trials in pediatric trial design. And this idea has been floating around for a number of years now, to integrate a Bayesian design from adult data to augment pediatric trials. What this would look like is that it would mean that data would emerge from adult trials and then be incorporated into pediatric design. Survey results of experts to consider relevance, as well as direct results from the studies themselves that are performed in adults, help better calculate a prior distribution of how you can calculate a sample size and design your clinical trial. And so in a sort of a schematic way, an adult trial gets performed. That data undergoes a Bayesian analysis to inform your pediatric trial so that you can start the pediatric trial with priors that are data informed and not just opinion. And so we're looking at a prior distribution graph. The red line is a skeptical prior where most trials would start, and the black line is the adult study prior. And by weighting them accordingly, depending on how you see fit, you need to understand that we may be able to gain efficiencies as relates to how we analyze pediatric clinical trials. The solution number two, and this is more novel, is learning from adult trials in real time. So you may have heard, and prior speakers have spoken about REMAP-CAP or REMAP-COVID, which is an adaptive platform trial that evaluates a number of different interventions simultaneously. And so what that means is that you can examine antivirals, convalescent plasma, and their interactions therein. As the trial accumulates data, response adaptive randomization assigns randomization and preferential probabilities to the arms that are doing better. What we are working on is a model that integrates the two, so that data that emerges from the adult studies informs pediatric trial design in real time. So if you are examining the same antivirals or the same interventions amongst children, you gain the efficiencies that the REMAP-CAP adult studies has, but magnify that to incorporate the priors that exist from those studies. At the same time, data from the child-specific randomized trial also informs that response adaptive randomization and declaration of outcomes. And one can weight the relative weights of the adult and pediatric data that emerges accordingly to get a fair assessment as to the accuracy and importance of the data that emerges. So when you look at our four main problems that existed, sample size, low event rates, heterogeneity, loss of equipoise, from a sample size perspective, you gain efficiency through borrowing from the adult interim analyses. From a low event rates perspective, using mortality is not going to provide us that benefit as it does in adult studies. And so alternate continuous outcomes such as organ support free days or time to recovery would provide greater efficiency at learning. Heterogeneity, with a statistical model that incorporates age and region into the statistical model, you can overcome a lot of the challenges of the heterogeneous treatment effects that have plagued our field for so long. And loss of equipoise. I think with a real-time co-analysis across age groups, both pediatric and adult, with clear stopping rules embedded, equipoise or the loss therein is partially overcome. So to conclude, pediatric adult data sharing at the same time from a co-analysis perspective will expedite learning across age groups. Obviously, this needs a great deal of coordination, primarily across funders, to make sure that the timing of trial dissemination is coordinated. But given current state of pediatric knowledge generation, a widespread paradigm shift is needed in how we learn. Thank you.